Thank you to Dr. Hassan Mustafa for this excellent lecture. As I have mentioned earlier, that two of our respected speakers are unavailable because of some unavoidable circumstances. So this concludes our session. Now I ask the audience, the forum is open for question and answer. If there are any questions, you can ask from speakers and chairpersons as well.
We've got a comment for a couple of these speakers. The speaker about the biological agents, he did not mention the cost for 1 month of a person, how much he will have to arrange for the cost. And I think we agree that these should be given in particular places. Not everybody should do it. In 2002, when I went to UK, when there was they were stopped us not to do practice. So I went to UK and I joined this rheumatology. And these were started there. In the hospital where I worked, there were only 8 patients. And they used to come for daycare. They were given IV. Now the oral is available. So there should be these 3-4 hospitals. They should have the rheumatologists from Northwest to KTH. And they should be referred particularly on those people. So if you can give us a clue how much it costs, that will be. My other question is about the young man, about the low back pain. I think it's not the physicians who always advise the MRI. It is usually our neurosurgical or orthopedic colleagues that they don't touch the patient. They just ask for MRI. And the other thing about the low back pain I want to ask is, there's a very common term used, arqun nisa. Now, nisa is women, but I don't know about arq. What is it? This is, though Masood Rahman will probably tell, is it an Arabic term or something? When the patient comes, I have got arqun nisa. So I don't know what is that arqun nisa. So why do people do MRI for people with arqun nisa? And the last was very good about the treatment of SLE. Masood Rahman has got a large experience about these patients. So we have got a pitfalls about these patients missing their doctor, the doctor is not available, somebody else him to go to another doctor, and this cycle stops. So most of our SLE patients at the end up with problems. So these 2 questions, those who are there, if they can clarify the cost, please.
Thank you, sir. Basically, as far as the cost is concerned, so I'll share my experience with LRH that luckily we have Baitul Mal, and those patients who are not able to afford biologics, we can register them through Baitul Mal, and they can get them from Baitul Mal. Since I started my training in 2019, so thanks to Dr. Sulaiman that he started this initiative, and now we are in consultation with the Sehat Sahulat program to include these biologics in that program, so that these patients, which are mostly poor patients, they can be able to afford these biologics. So though they are expensive, sir, but we have options like Baitul Mal, and now we are moving towards that Sehat Sahulat program. We are in consultation with the health minister to include these drugs in the program.
But those who can afford, how much?
Those they can afford, sir, I don't know exactly, because every biologic has different costs, like TNF inhibitors. I don't know the exact cost, but some of them are very expensive, some of them are not very expensive, so I'm sorry, I don't know. But out of them, that, like I delivered lecture on JAK inhibitors, like if some patients, like I mentioned in my lecture, that if they are not able, like you say, they have to come for injection to the hospitals. So the guidelines are, sir, now slowly changing and more toward oral molecules. So JAK inhibitor is another option for them. And those who can afford the biologics, we have some consultation with the companies, multinational and local, sir. We can guide them about the prices. They can give them some concession as well. So we will, I don't know exactly the prices, but we can guide them that how much is the cost, sir. Thank you.
I think I come to your rescuer here. As the saying goes, money talks and bullshit walks. You know, if you have to start someone on a disease-modifying drug, especially the ones which are expensive, I think we have to explain to the patient Many a time you will find people coming and telling you that I have sold my sole breadwinner, which was my cow, because I was selling 2 to 3 liters of milk, and I sold my house, and in the middle they are stuck up. The Baitul Mal people, they are helping. Even just about a week ago, I arranged, I happened to go to Chatral with my Tablighi friends, and there was one of our friends who needed a total knee replacement. The cost was more than 4 lakh rupees. But here the Baitul Mal people are very helpful. They have sent a check, and today I'm going to present it to the director of finance over here. So if you get in, previously one of my friends, Sultan Hanif, he was the Director General of Baitul Mal, and we would arrange lots and lots of money for different people, going into lakhs of rupees. So if I think you sort of get in touch with the Baitul Mal people, then they would be able to arrange for most of the drugs, which at the end of the day they are not able to tolerate, because most of the drugs, they need to be given for long periods of time, and if they don't have the money, I think, then they are lost.
Yeah. Thank you very much. I think I agree with Professor Mahmood Rahman Sahab. It's a shared decision with the patient. You have to decide. Don't impose your treatment on the patient, because we have a very limited resources. And definitely regarding Hamid Saab questions, what is the cost of different biologic have different cost. Like if you are treating a patient, you selected rituximab, so depending on its cost, like one vials will be having from 90,000 to 2 lakhs, depending on how much he or she needs at the moment. And TNF blockers, difference, we have multinational companies, local companies as well. But definitely if you ask a patient, you have to take it for years, and the cost is, monthly cost is 10,000. So it's also a lot for a patient at that times. That's why we here try our best to manage with the minimum possible cost. And that's why when we finished with all the conventional demands, then we move to that. And the final decision is between the patients and the physicians, which is best for cost effective, meanwhile about the disease activity at that times. The second question is regarding the availability of Baitul Mal. I think Baitul Mal is an option, but not starting a patient on tofacitinib as a very good lecture by Dr. Ibrar. But I think starting a patient, once you decided to start a patient on tofacitinib, you have to decide about different factors at that time, like why should I switch from conventional demands to tofacitinib? Either the disease is not controlled, whether I want to achieve the disease control a bit earlier. The half-life of this drug is very short. You can't taper it. You have to give it. If you start it, you have to continue at the same dose. And similarly, at the same time, if it's not controlled, you have to continue the conventional demand with that as well. That's why deciding on starting any patients on an expensive treatment, that will be a wise decision, not only depending on you have to control the disease a bit earlier, because you have to finish all other options, then you have to move it, because we have very resource limited country here. And the availability is available, but who will afford it? That's the reason.
Assalamu alaikum, everybody. I think I would agree with Professor Masood Rahman Sahab. As far as the cost of the drug is concerned, I think whenever there is a new drug coming to the market, the prices are always on the higher side. But as the time goes on, the prices become more and more affordable. I think the other point is you have to choose the right patient for the right drug. If the conventional demands are working, why to switch to the more costly and newer drugs? Yes, there is always room for new drugs to use, but you have to select the patient depending on his financial status, age, gender, and education. Yes, patient, as Dr. Lamdev has rightly said, it is basically the decision lies between the patient and your physician. They are the best judges, and they have decided which drug, has to be prescribed for a particular patient.
Thank you very much. I wanted to ask a question. This is Dr. Gibran, working as an associate professor at MMC General Hospital. I wish the last speaker was online, but since we have got a panel of experts, the last talk was about managing SLE in a low resource setting. So I would like to have a comment from the panel of experts, and if the speaker is online as well. We all know that it is a complication of the SLE that is disastrous for the patient. So what's your opinion about managing lupus nephritis in a resource-constrained setting when highly specialized treatment like biologics or dialysis are not available, because since patients are from the periphery? And the second is that can any strategy for managing pregnancy in lupus, because that is very important while highly obstetric care is not available. So what are your opinions and any suggestion on that?
If I take the liberty, most of the rheumatological conditions, if you take rheumatoid arthritis, it gets better with pregnancy, probably because of an interplay of the hormonal changes and the immunosuppression. So pregnancy will make rheumatoid patients better. And you should be careful again. It's a debatable point. Many people would disagree with me. But giving methotrexate and leflunomide in pregnancy would be the work of a daring physician. My friend Hamid would always say that if you start someone with suspected tuberculosis, it is an admission of failure. A very sort of, it is a daring thing to start someone on anti-tuberculosis without knowing the correct diagnosis. But then you need a very daring physician to stop it altogether. So, deciding indiscriminately people to be started on drugs which they can't afford, and coming to SLE, SLE gets worse with pregnancy. So rheumatoids will get better. Once the delivery, they'll get again, and they will go again, have an exacerbation of the disease. They would go in remission. People with SLE, they get worse with pregnancy, and it's a very, very trying situation, carrying both a high mortality and at the same time abortions, and those things are very common. As regards the management, I'll switch over to my friend. He will give you a small resume on the present.
Thank you. Regarding lupus nephritis, definitely depending on the treatment, we have different options for it. The best option here, like according to the recent guidelines, is your MMF, mycophenolate mofetil with steroids. But biologics therapy, again, sheer decisions, rituximab work, but not better than MMF. And similarly, cyclophosphamide is the drug of choice for every disease, unfortunately, because of the toxicities. And lupus is a disease of the childbearing age, if we consider it. Here, we are worried about the infertilities and the side effect of that. That's why better option first is MMF, mycophenolate mofetil, followed by, if it's not affording, and we discuss it, because there is chances of infertility if you choose it cyclophosphamide. But again, if it is life-threatening, the disease is not reversing, we give cyclophosphamide as well. And rituximab work, but if it is associated with cytopenias, cerebritis, all the disease is active, just not only the renal sides that is affected. If the disease overall is active, rituximab is another option as well. Pregnancy, definitely agree with Professor Mahmood Rahman Saab. It increases, the activity increases with pregnancy. But there are some drugs we continue with that. The better is you control the disease with tacrolimus and cyclosporine. Along with that, the low-dose steroids. But there is an option as well. You can continue even before starting the pregnancy, and you plan. It should be a planned decisions. If a patients come to you with high disease activity or they are planning for pregnancy, you can't delay it, because every patient with chronic diseases should not take decision on just to continue the pregnancy. You have to explain it, because you have to delay the pregnancy. But once the pregnancy is there are drug options, you can continue that just to control the disease.
Can I just add to this? We had a patient, some of our team at that time in 2005, we were still here around, and we presented that lady in our case history at that time. She had a lymph node, and a lymph node biopsy was done in Qatar. She was diagnosed as tuberculous. When she came back here, in spite of taking anti-tuberculous, she was getting worse. We admitted her once and then readmitted her. She developed side effects. And then we found out she has got SAD. That lady was seen, the whole team, and we had got a very eminent Dr. Fakir Mahmood. I showed it to her, and he advised her against pregnancy. 3 months later, when I went to Swat, she was pregnant. And she has had that baby, and still about 10 years old, that baby. So people get pregnant even if you tell them not to do it. So one has to be very careful about, tell them that should not have pregnancy, but they do get pregnant. Again, she was only on HCQ and prednisolone, and so she was not on any other medication. So that's another issue to remember, and that's right to talk about to the patient.
Thank you. I would add a point that pregnancy discussions, just like my colleague Alamzeb has described it, that pre-pregnancy counseling is very important, especially in the case of lupus, as Dr. Masood Rahman said that it gets flare-off in the pregnancy. So pregnancy is a challenge for lupus patients. So we have to discuss all the risks and benefits with the patients, whether the patient is ready for pregnancy or not. And then we have to screen them for certain conditions like anti-phospholipid antibody syndrome. In the guidelines, every lupus patient should be screened for anti-phospholipid and Rho antibodies, because sometimes the Rho antibodies can cross the placenta and it can cause complications of heart in the babies. So pre-pregnancy counseling, anti-phospholipid screening, and disease activity, any control of disease is very important. And then there are, just like Alamzeb told, that there are certain drugs, the bread and butter drug hydroxychloroquine, which is very safe in pregnancy, can be continued. It can prevent the heart block. It's had anti-thrombotic activity. It can decrease the flares. So there are lots of options which are safe in pregnancy. So please discuss everything with the patient. This should be a shared decision making. And so pre-pregnancy counseling is extremely important, because it can prevent lots of complications. Sometimes even the patient with lupus presents to us with miscarriages, and there are no other features. And when we do the screening of antiphospholipid, then that is positive. And that is another thing that we usually discuss with gynecologists. So pre-pregnancy counseling is very important.
Thank you very much. I'll just add a comment regarding SLE and its implications on the different systems. With it being a multi-system disease, I would strongly encourage all of my colleagues who are here today that working closely with the multidisciplinary team is key to the management. So if you're suspecting renal involvement, getting the nephrologist on board earlier. If you have a patient with pregnancy with SLE, I'm sure they're going to be under a gynecologist, but they'll need very close monitoring with regular fetal ultrasounds, looking at heart blocks. So my key message for this question would be you need to have a multidisciplinary approach to these patients, and one person or one physician alone cannot manage these complex patients.
You talked about Dr. Fakir Mahmood Khan. He was a son of the soil from the rest of Waziristan, from Miram Shah, and he was arguably the first consultant. He became a consultant rheumatologist way back in 1975. 1975 he was a consultant over there. I happened to work with him in 1980, and in 1981 he came back to Pakistan in the hope of establishing rheumatology over here. But somehow, by then he was not very much accepted, was put into the general medical unit, and he would repeatedly say that since he was a rheumatologist, he was a misfit in a general medical unit. He came back, but during that time, the locum who replaced Fakir Muhammad Khan was Dr. Kenneth Lloyd. And Kenneth Lloyd was one of the persons who was amongst the founding fathers of rheumatology in UK. And he would tell me that when in 1949, that was just after the partition, but for them after World War II, when they were establishing rheumatology, it was not sort of because everyone thought that it's the domain exclusively of the orthopedic surgeons. And he would repeatedly say that they had to put in lot and lot of efforts to establish rheumatology. So it's very, very nice to know, you know, when I came in 1985, we tried, in the medical unit, we would have a few beds exclusively for rheumatology, and my friends Hamid and Farooq Saab and my very close friend Farooq, Dr. Farooq, we were together in the same unit for 10 years, and they would all take care of my rheumatology patients because we would have just a small regular beds. When the new unit in rheumatology was being, lead reading was being established, the medical unit, which later on got converted into the surgical, we had 25 beds of rheumatology in it, but somehow, you know, the unit, but it's absolutely wonderful to find now fully established rheumatology units in LRH, in KTH, in HMC. Believe me, I could not dream of it when I was retiring. And now, by the grace of Allah, we have a rheumatologist practicing in Northwest. Everywhere. In every unit we have the private sector and the public sector. So it's a great achievement, and I think it adds to that one full session is being given to rheumatology in the Society of Physicians meeting. So I must congratulate all these young rheumatologists who are working so hard to bring this up as a specialty over here.
Just adding to you know, Dr. Gibran's question regarding lupus nephritis. When I was working in nephrology unit, basically, we came across a lot of these patients. Actually, you need to see whether the pregnancy is a planned one or, you know, unplanned one. If it's a planned one, the patient and the doctor can sit and always plan accordingly, right? It should be multidisciplinary, you know, decision. Unplanned pregnancy presenting to the OPD and having, you know, SLE, you need to see the patient, you know, clinically as well as, you know, lab-wise. If you are suspecting the disease activity is on the higher side, we tend to, you know, continue with the steroids, HCQ, and MMF. It's a quite beautiful combination. Again, as Alimteb would, you know, second me, depending on the stage of the, you know, disease. If it's stage 4 and 5, again, you have to, you know, see the benefit versus risk and, you know, deal that patient accordingly. Thank you.
Thank you very much, respected chairpersons, for their valuable insights. Now, I would like to call upon the stage Professor Dr. Masoodur Rahman and Professor Dr. Hamid Ahmad to present certificates to the speaker. Sir. The first speaker is Dr. Ibrar Hussain.
And I feel very sorry that we have lost one excellent physician just by making him a professor of a subject in which he would have helped all the PJ, including my son, who have difficulty in passing their FCPS Part 2 exam. So we would request him that he comes back into clinical medicine.
दरमियान सेंटर के Thank you. Dr. Hashmatullah. Dr. Hassan Mustafa certificate will be collected by one of our facilitators. Now I would like to call upon the stage Professor Dr. Farooq Ahmad, Professor of Medicine and Medical Education, Khyber Medical College, to give certificates to respected chairpersons. Dr. Qazi Ikramul Haq, Associate Professor of the Margara Medical Teaching Hospital. First certificate is presented to Professor Dr. Masoodur Rahman. Professor Dr. Hamid Ahmad. Dr. Ata Muhammad. Dr. Shoja Sharaf Gan Khan. Dr. Alam Zeb. And in the last, myself, Dr. Imran. Thank you. So this concludes our session. Now I would like to call upon the stage Dr. Sumaira Bakhtiar to take over for the next session. Thank you.